Mike Gibson, Roberto Diletti, coming to you live from ACC 2023. We're talking about the BIOVASC study. A lot of controversy out there about multi-vessel versus single vessel revascularization and acute coronary syndromes. Talk to us a little bit about what you did and what you found.
Yeah, thank you for having me. Yes, this is, first of all, the first large randomized trial comparing two complete revascularization strategies for patients presenting with acute coronary syndrome and multivessel disease. So in particular, we compare an immediate complete revascularization strategy versus a staged complete revascularization strategy, which mean staged PCI of the culprit lesion plus PCI of all non-culprit vessels with a significant lesion within 6 weeks. And we compare this in terms of clinical outcomes. The primary endpoint was a composite of all-cause death, myocardial infarction, unplanned ischemia-driven target vessel revascularization, and stroke at 1 year follow-up.
And what did you find?
So yeah, we found an interesting results. In particular, the immediate complete revascularization strategy was non-inferior to a stage complete revascularization strategy. So this is the first important finding. Basically, treating all the vessel during the index procedure is safe and was as effective as the stage revascularization strategy. If you think that the primary endpoints was 7.6% in the immediate complete revascularization group and 9.4% in the stage complete revascularization group, you understand that the non-inferiority was clearly met for this group. There are some other very interesting results in this trial. The first one is the event rate related to MI. So myocardial infarction was lower. The rate of myocardial infarction was lower in the immediate complete revascularization group compared with the stage complete revascularization group. And this was quite clear and significant from the data. If you think that the myocardial infarction in the immediate complete revascularization group was 1.9%, and in the staged complete revascularization group was 4.5%. So you see that there is a clear difference there. Of course, these results needs to be analyzed carefully because myocardial infarction, and in particular the periprocedural myocardial infarction, the procedure-related myocardial infarction, can be challenging to be identified during the immediate complete revascularization, while can be very easy to identify in the stage complete revascularization. So what we did was an exploratory analysis, removing basically all the procedure-related myocardial infarction, and still at that time we saw again that the non-inferiority was met, but also the myocardial infarction in the stage complete revascularization group were almost double compared with the immediate revascularization group. So there was a clear difference also in that group, although it was not any more significant at that point. There was a p-value of 0.052, so just not significant. Another interesting finding of this study is the fact that 44% of all infarction happening in the stage complete revascularization group are just in the time window between the index and the stage procedure. So, and those are not periprocedural MI. Out of those MIs that are 15 in total, 11 were spontaneous MI, and 4 were stent thrombosis of stent implanted during the index procedure. So a very significant portion of the MI in the stage group is happening in the time window between the index and the stage procedure. And this is quite something new as a result. I was used to think that a stage approach was definitely a safe approach, but these new findings are putting some question on that, especially if we wait a lot to plan this stage procedure.
Well, that was my bias as well, Roberto. I kind of thought, well, the stage would be safer. But you point out there are 11 spontaneous MIs with a staged. So that's nothing to sneeze at.
And the vast majority, so basically all except one case, were identified as MIs occurring in the lesion that was the original non-culprit lesion. So the operator treated the non-culprit lesion in those cases. So these are quite interesting result, I would say. And just a last point that I think is important to highlight is the unplanned ischemia-driven revascularization rate, which was lower in the immediate complete revascularization arm, was 4.2%, and in the staged complete revascularization group was 6.7%. But we try to have a lot of attention on not including anticipated staged PCI as an event. So basically, if revascularization occurred in the time window between index and stage PCI, was only included as an event if was triggered by an acute coronary syndrome. So only if the patient was presented with new ACG changes, not related to the normal evolution of the index event, or new rise of enzymes. Only in that cases, so only if there was a real acute coronary syndrome, then the revascularization was identified as an event and included in the primary endpoint. So we try to give as much as attention as possible in the avoidance of data processing bias.
All right. Well, somewhat surprising results, Roberto. Very, very careful work, though, and the analyses. Thanks for presenting it to us, and thanks to everyone for joining us here from ACC 2023.